This is a dysphagia presentation presented by Jessica Evans and Christine Poe. We will outline what dysphagia is, how it is assessed, and common treatment strategies. What is dysphagia? Dysphagia refers to a disorder or difficulty with swallowing. There can be a disturbance at any of the stages of swallowing. These include the oral phase, pharyngeal phase, and esophageal phase, which will be discussed in further detail in the next few slides. Swallowing is an extremely complex process involving 26 muscles. Dysphagia is not a disease or primary medical diagnosis itself, rather a symptom of an underlying disease process. For example, the following can contribute to dysphagia: Down syndrome, Parkinson's, cerebral palsy, motor neuron disease, stroke, multiple sclerosis, age, and dementia. The pre-oral stage kicks off the swallowing process. The purpose of this stage is to prepare the muscles and salivary glands to receive food or drink. This stage happens before the food and drink enter the mouth, and in this stage you are thinking about how you will eat and drink. Cognitive functioning plays an important role, as the awareness of the presence of food and drink can help in positioning of the mouth and the tongue. Factors such as smell, sight, temperature, and texture of the food influences the preparation process. Saliva is also produced during this stage, which activates the receptors, depending on the visual preparation of the food, so how appealing the food looks. Oral preparation stage. This involves the preparation of the food or liquid bolus in the oral cavity. The purpose of this stage is to break down food and form a cohesive bolus that is smooth enough to travel safely through the pharynx and esophagus. The tongue helps move food around the mouth, the jaw breaks down the food, and saliva helps to break down the food and moisten it. The lips, cheek, tongue, soft palate also help keep food and drink from spilling out into the nasal cavity and pharynx. Saliva is also produced to assist in forming the cohesive bolus. Once that is done, the tongue places pressure on the bolus to the back of the mouth, and this forces it into the pharynx.
The pharyngeal stage has two main purposes. One is it acts as a passageway for food, which propels the bolus all the way to the entrance of the esophagus using pharyngeal muscles. The second is airway protection. This ensures food and drinks do not enter the larynx, trachea, or lungs and prevents aspiration or penetration. This is done through the process of glottal closure and epiglottic deflection. Glottal closure involves the adduction of the true vocal cords and closure of false vocal folds over true vocal cords. For epiglottic deflection, the epiglottis tilts backwards to deflect the bolus away from the laryngeal vestibule. This is done by hyolaryngeal excursion, which is the upward and forward movement of the hyoid and larynx, which pulls the base from under the epiglottis, causing it to tilt. During the esophageal stage, the bolus is transported from the esophagus into the stomach. As soon as the food enters the stomach, the sphincter, which is called the UES, and allowed the passage of the food, then closes, which prevents reflux. Dysphagia has many different causes. It can be caused by genetics, for example, cleft palate or Down syndrome. It can be caused by developmental or congenital problems such as cerebral palsy. It can be acquired, such as stroke. It can be functional, so there's no known cause, or it can be iatrogenic from surgery. Medical consequences of dysphagia. There can be coughing and choking during mealtimes, penetration, which occurs when the food goes down the larynx, which is the windpipe, but does not go past the vocal cords. In this case, a cough reflex is triggered. Aspiration occurs when food goes down the larynx and enters the lungs. A cough reflex is also triggered. Aspiration pneumonia occurs when there is infection of the lungs due to aspiration. This occurs when lots of foreign material has entered the lungs.
Observable signs of aspiration. These can include coughing, a wet voice, watery eyes, and a red face. Silent aspiration occurs when the person is not aware that food has gone down the wrong way. A cough reflex is not present. Nutritional consequences of dysphagia. These can include weight loss, vitamin or mineral deficiencies, reduced immunity, and fatigue. People who have dysphagia may not be able to eat a balanced and nutritionally adequate diet. This may be due to difficulty communicating their food preferences or dependence upon others for help when eating. The person may limit the variety in their diet, selecting only the foods that are easy to swallow. Slow eating and the extended time taken to complete meals may also contribute to malnutrition. As a result, the person may not receive all the nutrition that they need to maintain a desirable weight. Dysphagia can also have psychological implications. Clients find increased dependence on carers at mealtimes and new feeding patterns as degrading and upsetting, which may further lead to anxiety, isolation and depression, and reduced quality of life. Individuals may also experience financial issues. We are going to take some time to brainstorm this question. During a mealtime, you notice that your client is experiencing discomfort. What symptoms or signs could you expect to see? You may pause the video for a few minutes and resume when you have finished.
There are many different signs and symptoms of dysphagia. The following are examples. Drooling or anterior spillage of food. This occurs when you can see visible drooling or food spilling from the mouth onto the chin or onto their body. Prolonged oral phase preparation time. They might be a slow eater or have delayed swallow, so the meal time takes longer than average. Nasal regurgitation occurs when food or liquid comes back up out of the nose. Difficulty forming the bolus, so they're unable to break down the food with their teeth, tongue. Coughing may be absent or weak. Coughing on saliva. Delayed swallow. Multiple swallows or effortful swallows. Choking or coughing when eating or drinking. Changes in posture during meals. Oral residue or scatter. This occurs when there's food remaining in the mouth post-swallow or post-mealtime. Changes in voice quality, for example, a gurgly or wet voice, and gagging or throat clearing. Factors which compromise the safety and function of the swallow are attention, alertness and cognitive function, insight and awareness, compliance, impulsivity, motivation, fatigue, behavioural problems, postural control, upper limb mobility and feeding dependence, environmental factors and distractions, for example, are there TVs on, are there lots of background noise, and available support. Speech pathologists assess for dysphagia breakdowns and do this through a number of methods. They will conduct a case history to gather relevant information from support workers, parents, or guardians. Case history includes information on the client's background, such as their diagnosis, their age, who they live with, their communication effectiveness. It can also include general observations that they note while they are conducting the assessment and case history, such as the individual's behaviour. Speech pathologists will also observe the client during a mealtime to observe any signs or symptoms that were previously mentioned, such as anterior spillage of food, prolonged oral phase time, delayed swallows, etc. They will conduct an oral motor examination, if the client is cognitively able to assess the range of movement, strength, and coordination of muscles involved in swallowing, and they may trial other liquids or textures. Primary treatment methods for dysphagia include diet texture modification, adjusting the environment, e.g. the positioning and equipment, compensatory and safe strategies, and strict oral care regime. These will all be explained and broken down further.
Why modify diet and/or fluids? If they can't chew properly, the bolus is not well formed and can lead to swallowing chunks that are too big, which may lead to choking. Food and drink can get stuck or move really slowly down the throat if muscles aren't strong enough to propel the food. or in many cases, things may go down too fast for them to coordinate their breathing and swallowing, leading to penetration, aspiration, and consequently aspiration pneumonia. For clients who have cognitive difficulties, they may not recognize food, they may have loss of appetite, they may chew too quickly or slowly, or forget food is in their mouth. There are different levels of thickened liquids and diets. There are thin fluids. These are unmodified, for example, water or milk. Level 80, which is slightly thicker. Level 150, mildly thick, and it's a nectar consistency. Level 400, which is moderately thick and is a honey consistency. Level 900, which is extremely thick and is the consistency of pudding and custard. With diet, you can have an unmodified diet, so everything like steak, a soft diet, which is texture A, minced moist, which is texture B, and a puree diet, which is texture C. Here you can see the different liquid consistencies and diet textures. The food pictures are an example of what clients would normally get for their meals for the different textures. This is an unmodified meal. The previous slide showed the modified textures of this meal.
Texture A is known as the soft diet. It cannot have any crunchy or hard foods like nuts or grains. It is broken into 1.5 centimetre bite-sized pieces. Foods that are suitable include bread with no crust, soft fill sandwiches, pasta, rice. You want the rice to be gluggy so that it doesn't break up into smaller pieces. Well-cooked vegetables, fruit without the skin, and dairy products. It is important to avoid tough meat, stringy vegetables like celery, bread with grains, muesli, hard crackers, nuts, seeds, fish with bones, and dry foods. You need to be aware of bite and dissolve foods like a crusket, where it's hard to bite but once in the mouth it dissolves. Texture B is a minced moist diet, with pieces no greater than 0.5 centimetres in size and that can be broken easily with a fork. Texture B is coated with thick sauce to provide cohesion to the bolus so that it's moist. Lumps are soft and rounded. The diet might be recommended for someone who has reduced saliva. Suitable foods for texture B include porridge, cut up pasta, finely cut up tinned fruit or soft vegetables, steamed fish, and minced meat. Avoid the same diet recommendations from texture A and mixed textures, for example, fruit in juice, cake, and biscuits. Texture C is a puree diet. Absolutely no lumps, but no bleeding, so food can still be separate. Anything that can be provided in smooth puree and blended is fine. For example, steak. As long as it's blended, that's okay. Recommended for clients with oral phase difficulties who can't manipulate the bolus. Thickened fluids also recommended for clients with poor oral phase. Suitable foods include strained yogurt, pureed fruit, melted cheese, ricotta, salmon mousse, vitamized meat, vegetables, and creamy scrambled eggs. Commercially available, you can get foods like yogo, snack packs, custard, and jelly. You want to avoid anything that's not pureed. Making thickened fluids. The instructions for how to make thickened fluids are on the back of each container. However, each consistency requires a different amount of powder. Remember to check the dose guide carefully for the quantity of fluid you are thickening. Continue to stir as you pour the powder into the water for 1 to 3 minutes to also ensure that there are no lumps.
There are different types of thickener brands. Resource Clear Thicken Up is just one brand. Some other brands you may come across include Carry Care, Quick Thick, and Easy Thick. Level 150 fluid is mildly thick. It's a nectar consistency which runs freely off the spoon but leaves a mild coating. You can drink this level from a cup or straw. Level 400 is moderately thick. This is a honey consistency. It slowly drips in small lumps off the end of the spoon. For clients with a significant difficulty triggering a swallow, for example, sensory difficulties, motor difficulties, inadequate seals, and reduced coordination. Because it is thick, it gives clients more time to coordinate and manage and don't need stronger pharyngeal muscles. Level 900 is extremely thick. It is a pudding consistency which sits on the spoon and does not flow off it. It has implications because clients need their food but also need their hydrations. Because it's so thick, it's like a meal, so you need to make sure they are adequately hydrated.
Some considerations to keep in mind. Watch out for foods that change in consistency in the mouth. For example, ice cream becomes a fluid, not suitable for those on thickened fluids. Mixed consistencies requires extra coordination. For example, fruit in its juice, like cup fruit or tin fruit, and watermelon. High choking risks include foods that are stringy, like celery, crunchy, crumbly foods like popcorn, hard and dry foods like nuts and seeds, floppy textures like lettuce and spinach leaves, and tough textures like steak. Chewy, sticky foods are also high choking risk, and these include dry fruit. Modifying meal times is another treatment strategy for dysphagia. You may need to modify mealtime activity to meet needs of the individual, for example, altering their mealtime to align with medication times or the use of feeding aids. Mealtime schedules are important for some patient groups. For example, they might be more alert after meds or before meds, etc. Small frequent meals may be better for some. They may need reduced environmental distractors, for example, the TV off or no music playing. Bolus control techniques include prompting the individual for multiple swallows, placing the bolus on one side of the mouth, prompting them to clear oral residue in their mouth with their tongue, finger, or with water. Another modifying mealtime strategy is making sure the client is sat upright, so their torso should be directly underneath their bottom. These are some examples of modified equipment. Plates with a lip ensure food doesn't fall off the plate, and utensils with grips are often easier to hold and lighter than metal utensils, so they may be helpful for someone with poor, fine, and gross motor coordination. They can also be safer if the individual often bites down on their utensils frequently during mealtimes. Modifying position is another strategy which requires interprofessional involvement. This includes nurses who can help to position the residents and patients for a safe feeding experience and help with appropriate feeding. Occupational therapists help with specific utensil requirements. Physiotherapists help with appropriate positioning, for example, for wheelchair residents. And care staff help with appropriate feeding.
It is important that the person is sitting straight for safe eating or drinking. The legs can also be bent at the knees, as shown in the first picture. Ensure that the person is not positioned where they are leaning too far back, as shown in the second picture. Make sure the person is sitting upright with both feet flat on the ground, as shown in the first picture. Do not stand to feed someone, as it makes them look up, which can be dangerous for people with swallowing problems. Sit opposite and eye level to the person you are feeding, as shown in the first picture. Do not feed them from the side unless the speech pathologist has asked you to do so. Make sure the person's head is at 90 degrees and not tilted too far back.
Some standard safe swallow strategies include ensuring the client is fully upright and alert for oral intake, so their positioning. Again, their torso should be directly underneath their bottom. Small mouthfuls and time to chew may be needed. Alternating mouthfuls of food and drink, for example, might be 1 spoonful of drink per 2 spoonfuls of food. Check mouthfuls and time to chew to ensure the individual has effectively broken down the food and finished that spoonful before providing the next. Maintain optimal oral hygiene, for example, brushing their teeth. Cease oral intake if coughing, fatigue, or difficulty is observed, and you can note the level of supervision and assistance required. Oral care is important as aspiration is prone to clients with dysphagia. Hence, the oral cavity and any secretions they aspirate on should be as clean as possible. This prevents aspiration on bacteria-filled secretions. An increased risk of aspiration is associated with poor oral care, and regular oral care is necessary. Good oral hygiene is important because it improves mealtime enjoyment and maintains nutritional status. It prevents infection and bad breath, prevents aspiration pneumonia, and poor oral care can lead to tooth decay, dry mouth, and plaque. Risk factors for dysphagia-related poor oral hygiene include pocketing of food in the mouth, reduced tongue movement, and the inability to detect and clear residue after meals.
This is what poor oral hygiene looks like. Oral care recommendations. Ensure clients take water after meals and medications to flush away any food or medication residue in the mouth. Complete regular quick mouth inspections. Prevention is the key. Get the client to open their mouth and say "ah." Look inside the mouth for any food, medication stuck around gums, tongue, or teeth. Encourage them to flush down with fluid or, if necessary, clean out. Follow any recommendations provided by the speech pathologist. Prevention of dysphagia. Recognize the risk factors for dysphagia and aspiration. Monitor any dysphagia signs. If the client is exhibiting dysphagia and/or aspiration signs, refer to a speech pathologist immediately. Ensure all recommendations and safe swallow strategies by the speech pathologist are implemented and followed, especially the foods and liquids to be consumed.
Thank you for listening to this dysphagia presentation.